We're going to be bombarded today with a lot of data, so I tried to be kinder and I eliminated 40% of those slides. So I chose to focus on what's relevant in daily clinical practice. So I see Todd there. Sorry, Todd, I didn't put anything about neoadjuvant because it's still not prime time in terms of phase 3 trial. But I will be focusing on what's actually relevant in the clinic here today that we do day in and day out for patients with metastatic non-small cell lung cancer, as well as locally advanced non-small cell lung cancer, as well as extensive stage small cell lung cancer. Just a brief update relevant to one target therapy for the audience that did not receive any of the alert from ASCO yesterday. The FDA actually released an accelerated approval for lorlatinib, which is a next generation selective ALK inhibitor, which has advantage over the current generation ALK inhibitors currently in the market previously, because lorlatinib has activity against the gatekeeper mutation G1202R, which arises as a resistance mutation when exposed to like crizotinib or alectinib or brigatinib. So here's our pre-test. So in the clinic, this is not an uncommon situation. A scenario, 56-year-old female, she's a never smoker, unfortunately diagnosed with stage 4 adenocarcinoma of the lung, metastatic to the brain and liver. Her PD-L1 is greater than 50%. The molecular testing is fortunately back. All of them were negative, no mutation. So which of the following would you recommend to the patient? Which one do you agree with the most? So number one is addition of Bevacizumab on top of chemotherapy and immunotherapy. Sufficient enough to overcome any negative association of liver metastases. So the second question, is that statement true? Is there a negative association of liver metastases on immunotherapy efficacy? So you have to make sure, are both statements true? Number two, so for patients with brain metastases like her, they do not really benefit from the combination of chemotherapy and immunotherapy more than just chemotherapy alone. And number three, pembrolizumab as monotherapy is highly recommended due to better efficacy compared to chemotherapy in the setting of PD-L1 greater than 50%. Oh, great. So hopefully you'll get the right answer at the end. All right, number two. In extensive stage small cell lung cancer, overall survival benefit of immunotherapy compared to standard of care chemotherapy has been demonstrated with, number one, first-line pembro monotherapy in PDL greater than 50%. Remember, this is small cell. Number two, as maintenance therapy for immunotherapy, pembrolizumab in patients with complete response, partial response, or stable disease after first-line chemotherapy. Number three, chemo plus atezo as first-line therapy. Number four, nivolumab as second or third-line therapy. Number five, all of the above. Number six, none of the above. Sorry, this arrow is not cooperating. Okay, good. So if you want me to come back next year, hopefully you'll get all the right answers. If you get a little confused because there's just a lot of data, I'll be summarizing the slides, so if you pay attention to the summary, you should be able to get the answers. All right, so let's start with metastatic non-small cell lung cancer. So this slide is just to demonstrate to you how quickly changes have been introduced to the standard of care. These show the approvals for immunotherapy, starting with second-line nivolumab in 2015. And within a year and a half, PD-L1 greater than 50% as frontline therapy was introduced with pembrolizumab. And then a few months later, frontline chemotherapy plus immunotherapy was introduced. And then earlier this year, durvalumab was approved. So I'll be reviewing all of these data, provide some nuance and editorializing from my perspective. And this is just to show you how our heads are spinning. It's creating a lot of questions in terms of how best to incorporate all this data into our day-to-day practice. And just for comparison, the line below shows you, when pemetrexed was approved as second-line therapy for non-small cell lung cancer, it took 5 years for it actually to move to approval in the frontline setting. So there's just a lot of things changing. So just a brief reminder of where this all started. Keynote-024 randomized patients with non-small cell lung cancer, both non-squamous and squamous histology, as long as they're EGFR and ALK negative, who have PD-L1 greater than 50% to either pembrolizumab or the appropriate chemotherapy doublet. And as this graph shows, pembrolizumab is the winner. You can see the curves are consistently better than chemotherapy. And so no question there, we have a winner. This has been incorporated to our daily practice. But there are a few nuances that I'll go over later. So next up, then the question is, since the curve still continued to flatten, we know even in those patients who are best selected, pembrolizumab alone probably is not a sufficient treatment for some group. So then the next question is, will addition of chemotherapy overcome some of the deficiency? And so Keynote 189 combined pembrolizumab with pemetrexed-based platinum combination for induction up to 4 cycles, followed by pembrolizumab maintenance. This is placebo-controlled in the non-squamous setting. For the squamous population, Keynote 407 essentially evaluated the same combination using either paclitaxel or nab-paclitaxel as the combination backbone. And so here's the important slide. In the overall intention to treat analysis, both non-squamous and squamous histologies, these trials also, again, included only patients with EGFR and ALK wild-type non-small cell lung cancer. So here we see, again, a combination is better compared to placebo. So when the results were initially announced, the initial questions to people were, well, is this effect just mainly seen in patients with PD-L1 high, since we know PD-L1 greater than 50% pembro will work as first-line therapy? Or is it true regardless of PD-L1? How large is the magnitude of difference that we will observe? And so here are the subgroup analysis. So we see indeed true that patients with greater than 50%, they do have better outcome with chemo and pembro, in fact, compared to the chemo alone. You can see the relative risk reduction, hazard ratio of 0.42, compares favorably to the hazard ratio of monotherapy of 0.6. The hazard ratio in the squamous population compares also very similarly. So remember this splay or this difference. As you can see, as the PD-L1 cutoff decreases, you'll see the hazard ratio increase, meaning the magnitude of effect is decreasing in the non-squamous population, but still we see the difference that chemo and immunotherapy is better. Look at for squamous, hazard ratio is very similar to whether it's greater than 50% or less than 50%. And in patients with less than 1%, here is where the important information is, and certainly very reassuring, that even in patients who are least likely to respond to monotherapy either in the second line or third line setting, that the frontline combination with chemotherapy may actually boost survival benefit with a hazard ratio of 0.6 in the non-squamous population. In the squamous population, you can see regardless of PD-L1 cutoff, this effect seemed true. So what created more confusion in ASCO when the Keynote-042 study was announced, and I'll show you what the study design is. So this study design included patients with non-small cell lung cancer, again, EGFR, ALK, wild type, frontline setting with PD-L1 greater than 1%. So can we use pembrolizumab as single agent? Essentially, that's the question. Keynote-024 looked at greater than 50%. So now the question is, well, can we look at 1% since all the other second-line therapy demonstrate benefit in that setting? So can we move it to the front line? So chemo versus pembrolizumab, either histology, as long as they're EGFR and ALK negative. So here is the survival analysis for intention to treat for all patients accrued. So for TPS greater than 1%, median survival favored pembrolizumab as frontline therapy. Survival benefit is statistically significantly better than chemotherapy. And so this created a buzz. Oh, pembrolizumab is better than nivolumab because if you recall, the Checkmate 026 that was released last year, very similar design in PD-L1 greater than 5% of non-small cell lung cancer. Look at these curves. The nivolumab was not better than chemotherapy. But hold on to that thought because realizing that what we're observing here in Keynote-042 may be somewhat artifactual. Pembrolizumab and nivolumab has already been approved as second-line therapy in North America, but this Keynote-042 study was conducted worldwide, and so they included countries where immunotherapy is not a standard of care yet. And so only 20% of patients actually in the control arm had exposure to immunotherapy. And so you may say that perhaps their survival benefit was demonstrated because the control arm actually got inferior care in a sense. If you're here in America, you should be getting second-line immunotherapy if you didn't get it front line. So this would probably explain why Checkmate was negative, because 60% in the control arm actually got the appropriate therapy in the second-line setting. Only 20% did in Keynote-042. Another important note is that when they did an exploratory analysis in the less than 50% but greater than 1% group, you see that there is a group of patients that will have better survival with pembrolizumab rather than chemotherapy. But this arm, this initial dip in the survival curve suggests that there are patients who really do not benefit from immunotherapy. And these curves eerily remind us of another study in target therapy using gefitinib, the IPASS study, that enrolled patients based on clinical features. So patients with adenocarcinoma, non-smokers. So you're enriching for potential EGFR mutations. But when this study was done, IPASS study back then, over 10 years ago, we were not sure of what the predictive marker would be. So we used clinical features. And what IPASS study showed is you cannot use clinical features because there will be a group of patients who don't benefit, and years later we understand, yes, because target therapy is indeed targeted. It will only work in patients with EGFR mutations. And we know non-smokers, adenocarcinomas may have other driver mutations that will not benefit from an EGFR TKI. So that will explain why there's this dip, but then it selects out for patients who benefit. So for IPASS study, what we know, clinical features is not enough. You need a predictive biomarker. So I'm setting this stage in explaining that TPS of greater than 1% is an insufficient biomarker. We need a better biomarker to help us select who is best going to respond to pembrolizumab as monotherapy. So going back to the Keynote-024 and Keynote-189 comparisons, I wanted to point out in relevance to our first pretest question. So we talked about PD-L1 greater than 50% probably can benefit many clinical subgroups, but I'd like to hone in on to this particular subgroup of patients who are never smokers. Granted, it's a small population. You can see the number of events were only 12 out of several hundreds, but yet it is worrying. Hazard ratio of 0.9 with a very wide confidence interval, indicating there are patients who may be harmed with PD-L1 greater than 50% who are never smokers if you use that as the first treatment. And probably this is because these may be patients who are EGFR positive, right? And we know as a single agent, pembrolizumab or nivolumab, they just don't work very well for the majority of patients with that molecular phenotype, genotype. And so keep in mind, if you see a patient, frontline setting, never a smoker, even if they're EGFR wild type or ALK wild type, you should pause about giving pembrolizumab as monotherapy. In contrast, Keynote 189 in never smokers, you can see immunotherapy did not have this concern, that chemo and immunotherapy is better than chemotherapy alone in all subgroups, including patients who never smoked, including patients with brain metastases, all right? So here's the brain metastases slide. So again, pointing out that yes, hazard ratio is favorable. More than likely, most of your patients will benefit, but because hazard ratio crosses 1, you just don't know if there may be patients who will be harmed. This is the subgroup analysis comparing the squamous population with the non-squamous population, both getting chemo and immunotherapy. And I just want to point out, even though for PFS, there seemed to be a linear relationship with PD-L1 expression and the magnitude of benefit in terms of survival. In terms of overall survival, while this relationship is observed for the non-squamous population, again, it seems like regardless of PD-L1 cutoff, you see benefit in the squamous population. So the take-home message is just because the PD-L1 is low should not disincentivize you from administering chemotherapy plus immunotherapy combination if the patient is fit enough to get the triplet combination. So on that note, chemo and immunotherapy is not for everyone. Increased rates of diarrhea, rash as any risk. And in terms of grade 3 to 5, increased febrile neutropenia. And in fact, if you look at the subgroups, patients who got triple carbo, PEM, and pembrolizumab had higher rates of death, in fact, compared to the control group. But it's just that treatment-related deaths. It's just that overall, there's largely more benefit. So in the end, overall survival is positive. So if your patients are frail, you're concerned about potentially febrile neutropenia, triplet combination may not be the best. Nonetheless, this slide shows that in terms of quality of life, cancer-related symptoms in terms of anorexia, shortness of breath, cough, it favors the triple combination. And this same theme we see with the squamous population, cough, decreased appetite, shortness of breath is better with the triplet combination, but increased pneumonitis, increased autoimmune hepatitis, grade 3 to 5, so these are serious in patients who got the triple combination. So use with caution, but this has set us a new standard of care for triple combination regardless of PD-L1 positivity. So then the next question is, well, there are other combination chemotherapy backbones that we can use for our non-squamous population, namely taxane with bevacizumab. So will this phenomenon be observed specific to the pemetrexed regimen, or is this universal in other chemotherapy backbone. So Empower 150 explored this question of a triplet combination, platinum, paclitaxel, bevacizumab, in combination with atezo, compared to the control group, which is carbo-paclitaxel and bevacizumab, and arm A, carboplatin, paclitaxel, and atezolizumab, essentially without the bevacizumab. And the other main important distinction between this study that provided key information compared to Keynote 189 is that it enrolled patients with EGFR and ALK mutation, about 10%. And so we will be looking at that subgroup analysis because it yielded interesting data. So this is the overall survival curve. This was announced in ASCO this year, published in New England Journal of Medicine. So the triplet combination shows better survival compared to chemotherapy, hazard ratio of 0.78. Here are the 1-year and 2-year overall survival rates. And I just show you, for comparison, arm A, which is the chemotherapy without bevacizumab plus atezo group. So you can see it appears to be indeed slightly better than the control group, both in the 1-year arm, both in the 2-year survival. Hazard ratio certainly pointing in the right direction, but survival is not statistically significant at this time. It may be with longer follow-up, but at this point it is still not positive. But I'd like to point out two key interesting observations in this Empower 150 study. So first one, the subgroup of patients with EGFR and ALK. So the atezo-bev combination showed a hazard ratio of 0.54 in terms of overall survival. Clearly, you can see a difference in survival curve. You don't need a laser pointer to show the difference. You can clearly see it with your eyes. So certainly quite striking. And in comparison, the non-bevacizumab containing immunotherapy chemotherapy arm, while showing some hints toward survival benefit, appears to be less robust compared to the bevacizumab containing arm. Another clinical group that is interesting is patients with liver metastases. We know patients with liver metastases, in fact, may not respond very well to immunotherapy on its own. And so the combination with bevacizumab appears to overcome the limitation of this clinical scenario. And we see patients with liver mets actually have a hazard ratio of 0.54 with the bevacizumab combination. Here, median survival of 13 months compared to 9 months. So the next study is Empower 130, essentially similar design, non-squamous, now looking at nab-paclitaxel. I wanted to show this mainly to demonstrate this slide. So here, there is a survival benefit of chemotherapy plus atezolizumab. So we just wait for Empower 150 for the arm A to be positive. More than likely it will be with continued follow-up. But the more striking thing is I wanted to show you this subgroup analysis, both in the progression-free survival and overall survival standpoint. Patients with liver metastases appear to not really benefit too much from chemo plus immunotherapy in the absence of bevacizumab. So here's what the drive-home message that I wanted to give you. Whereas patients without liver metastases, sure, clearly chemo plus immuno is better than chemotherapy. Same thing in terms of overall survival. An EGFR subgroup for this carboplatin nab-paclitaxel combination, while hazard ratios are certainly favorable, you can see the curves do not separate out much. And here is the side-by-side comparison. The two on your left represents what we saw on the Empower 150 containing bevacizumab, without bevacizumab. So it seems like we may have a winner. So for patients who have EGFR and ALK, after they progress on EGFR TKI and there's no other target therapy available, and now it's time for chemotherapy. We actually have data to support doing chemotherapy plus bevacizumab plus an anti-PD-1, anti-PD-1, in this case, atezolizumab. IMpower132 is a combination of atezo and pemetrexed, because there's always this question, oh, maybe the anti-PD-1 drugs are better than the anti-PD-L1 drugs. So this is just to demonstrate to you that they're probably all the same. Even though this is just to show you the key demographics. The experimental groups are just slightly more younger patients enrolled, but overall they're highly similar. So the overall survival for IMpower132 is not mature yet, but in terms of progression-free survival, we see benefit for the chemo plus immunotherapy. Again, the take-home message: patients with liver metastases, hazard ratio that cross 1. But median PFS, whether your combination is of platinum pemetrexed is with atezo or it's with pembrolizumab, the curves could very well be overlapping. They look very similar. This is the interim overall survival curves. A lot of these curves depend also on the magnitude of crossover from the chemotherapy arm to getting second-line immunotherapy, so may explain the magnitude of difference. So after all this discussion, I hope I implanted in your thoughts that there are indeed additional biomarkers that we need to help select out patients who will benefit from immunotherapy alone, or vice versa, who needs something more than pembro or nivo alone. So the emerging biomarker du jour is tumor mutation burden. It appears to be predictive for outcome across multiple tumor types, not just non-small cell lung cancer, but melanoma, colon, and in small cell lung cancer. And we have seen that tumor mutation burden is not correlated with PD-L1. They're independent, so tumor mutation burden using 10 as a cutoff using the Foundation Act platform, whether it's greater than 10 or less than 10. PD-L1 less than 1% comprises about 30% in each group, largely PD-L1 positive. Checkmate 227 is this trial that really took TMB as a marker to the next level. So this study stratified patients according to PD-L1 expression and then randomized them either to chemotherapy versus nivolumab versus nivolumab plus ipilimumab if their PD-L1 is greater than 1%. If it's less than 1%, since we know immunotherapy on its own should not be used, so the experimental arms are chemo plus nivolumab or nivolumab plus ipilimumab, with primary endpoint looking at PD-L1 as a co-primary analysis, looking at these two arms. So for this group of patients, about 44% had TMB greater than 10, so TMB high. But I want to point out that although 95% of patients enrolled actually had tumor samples submitted, less than 60% actually have TMB data available, to illustrate to you that even this biomarker is not the easiest biomarker to have. Turnaround time is long, so you may not have real-time data at the time you're seeing your patients. And a bioinformatic platform may be difficult. You need good DNA quality, so only 60% of patients, even in this trial, only had available data for analysis. But it is what it is. So whatever data they have, they've shown that patients with high TMB, regardless of their PD-L1 expression, whether it's greater than 1%, or more relevantly, what we are interested, patients with less than 1% expression, in fact, immunotherapy with EP and nivo combination is better than chemotherapy alone. And when you look at these subgroup analysis, looking at the composite of TMB plus PD-L1, if TMB is greater than 10 and PD-L1 is low, you can select out a group of patients who will have 1 year progression-free survival of 45%, clearly striking with the combination nivo-ipi. In contrast, if your TMB was low and PD-L1 was less than 1%, it didn't seem to matter whether you got chemo alone, chemo plus nivolumab, or chemo or ipi-nivo. So a promising biomarker. Preliminary overall survival in total for patients with high TMB appears to be favorable. It's not yet mature, so this is not statistically significant yet when this was reported out in April. But I just wanted to show that they're submitting this for regulatory approval using TMB as a marker. So a press release a couple weeks ago from to be unnamed sponsor, because you need for your CME points. I should not be saying any sponsor name, but you should know where, where this came from. So nivolumab plus ipilimumab as first-line therapy. So additional information was requested. They wanted to see what about the survival benefit in TMB less than 10. So if you want to say your survival benefit is greater, that there is survival benefit in high TMB, if it's going to be a true predictive marker, then you have to show that it doesn't reveal any benefit in the low TMB category. So what the exploratory analysis show is that in patients with TMB less than 10, ipi-nivo actually had a hazard ratio of 0.78 compared to chemo. So that meant the combination of ipi and nivo in TMB less than 10 was actually better than chemotherapy, and this hazard ratio was actually very similar to what the hazard ratio that was achieved when TMB was greater than 10. So maybe TMB is not the best marker, at least by itself at this point. So then the next big question is, what's the substratification according to PD-L1? Remember, PD-L1 and TMB are not linearly correlated. So you have 70% in both groups that have PD-L1 low. So yes, you will have patients who will benefit from immunotherapy alone because there are groups that will have PD-L1. So how does the subgroup of composite of TMB and PD-L1 look? So that's a big question. We await further analysis, but here's what it is. TMB on its own, I don't think is a marker on its own based on this initial press release. So we await further data. Anyway, so this was the algorithm that Solange Peters presented in her discussion after ASCO when Keynote 407, Keynote 042, Checkmate 227 were presented. So incorporating potentially PD-L1 and TMB low, if you see that, perhaps you should sway away from immunotherapy and consider maybe only chemotherapy. But in reality, as of November 3, 2018, TMB is not yet prime time, so what we have is PD-L1 greater than 50% as frontline. You can use pembrolizumab alone. Pembro is king. For less than 50%, you have the option of chemotherapy plus immunotherapy, either pembro or atezo. Empower 150 data would seem to suggest for your EGFR ALK positive subgroup of patients after TKI progression, you should consider a bevacizumab containing backbone. So moving on to unresectable stage 3 lung cancer. This is a Pacific trial. This is the first study to show a new standard of care in unresectable stage 3, which for the longest time, the standard of care is chemoradiation and nothing else. And so this study randomized patients within 42 days after they finished concurrent chemoradiation to either durvalumab, an anti-PD-L1 agent, or to placebo treatment for up to 12 months. And so in 2017, last year, we first heard about this, and that's why it led to its approval earlier this year. Durvalumab was better than placebo in terms of progression-free survival. And in World Lung this year, about 6 weeks ago, we have heard the updated overall survival analysis showing that indeed durvalumab is better than placebo. They incorporated pre-specified analysis according to PD-L1, given that it's durvalumab using their antibody. In their studies, they've used 25% as a cutoff. Subgroup analysis appears to suggest it didn't seem to matter regardless of the PD-L1 cutoff, but if you look at less than 1%, durvalumab may not be all that beneficial. But this is a post hoc analysis. It wasn't pre-specified. Another important feature is that in contrast to Keynote-024, if you remember frontline therapy, we mentioned never smokers just do not appear to benefit very well. Well, in Pacific trial, patients who are non-smokers, and actually this included patients who are never smokers, not just former smokers, patients who are never smokers, in fact, actually benefited from durvalumab. So puzzling, but interesting. And so should not deprive your never smokers a chance to get durvalumab based on this subgroup analysis. However, this is my editorial because I don't really see this discussed much or covered too much. And so I may offend the sponsor for this CME activity, I'm sorry. But I wanted to show that, again, and it's not due to the study being stacked for failure in the control group. It's just the way it is. When the studies were done, second-line therapies in many countries, they don't have access to immunotherapy, all right? But in this day and age with immunotherapy as frontline therapy or second-line therapy commercially available, FDA approved, we have to know that the control group got exposed to immunotherapy to truly say that the consolidation immunotherapy after chemoradiation is truly better, only if your control group actually had the chance to get the appropriate therapy at the time of progression. So the placebo group here, the control group, only 22% of them actually had some form of immunotherapy at the time of progression. This represented only 40% of all patients who actually got some form of treatment, right? So to me, that is worrying. When you look at a 2-year difference of about 10%, could that 10% difference be all attributable to the fact that you did not give a good group of patients the appropriate second-line therapy? So to me, yes, we have a new standard, but this is based on old standard of care. So may not be all that relevant, but it is what it is. So in the absence of survival benefit, if you have quality of life improvement, that will actually be another legitimate reason to adopt the use of durvalumab. And this was presented last year using EORTC, QOL, as well as the lung cancer specific questionnaire. There seemed to be no difference in improvement in quality of life, whether they got durvalumab or placebo. There may be a little bit here in terms of other pain, whether patients received benefit from durvalumab. But it was like one small domain. The overall domain for quality of life and physical functioning was not different. So that's my 2 cents in terms of durvalumab. So then the last few slides, we'll talk about small cell. So in fact, the first immunotherapy that was tested in small cell was ipilimumab. And ipilimumab plus chemotherapy was not better than chemotherapy alone. So it was tough to beat. This was the holy grail. How can we improve on the standard of care in extensive stage small cell lung cancer that had remained unchanged for decades? And so we have awaiting results from Keynote-604, looking at chemotherapy plus anti-PD-1 or anti-PD-L1 with or without anti-CTLA-4 drugs. So Keynote and Caspian studies, they're up and coming. We will hear about the readout soon. In the maintenance setting, Checkmate 451 is in the works. The randomized phase 2 study of pembrolizumab was reported a couple years ago. That was negative. The second-line therapy of Checkmate 331, investigating nivolumab versus topotecan or amrubicin, was actually reported out in a press release recently to be negative. We don't have the full details on, the magnitude of benefit. Is it inferior? Is it just no superiority? How much of a post-progression exposure to immunotherapy in the control arm receive immunotherapy. So all these are big questions that we don't know, so we will wait, but the data is there. Press release, it's not better than second-line therapy at this time. But to save the day for immunotherapy in small cell, we have IMpower 133, investigating carboetopuside plus atezolizumab versus carboetopuside in patients for frontline therapy. So we heard this in World Lung 6 weeks ago. The combination with atezolizumab was better than chemotherapy. So for the first time now, we have the only study to date so far in terms of overall survival benefit of immunotherapy is in combination with chemotherapy as frontline in small cell lung cancer. And across many patients, you see improvement. This note liver metastases patients, confidence interval crosses 1. So in conclusion, first-line chemotherapy with an anti-PD-L1 agent has shown better overall survival in small cell lung cancer. So this is the very first study to demonstrate that in IMpower 133. We await FDA approval soon. First-line chemotherapy with either an anti-PD-1 or anti-PD-L1 is better than chemo alone in advanced non-small cell lung cancer, and this is true for patients with or without EGFR mutation, and it's true regardless of PD-L1 status. However, we know that addition of bevacizumab based on the subgroup analysis that we demonstrated earlier is that patients who have EGFR and ALK do derive better benefit, it appears, when bevacizumab is added. Patients with liver metastases also appear to have better benefit if bevacizumab is added. Overall survival improvement is shown with durvalumab as consolidation therapy in patients with unresectable stage 3 non-small cell lung cancer after chemoradiation. However, the caveat is that quality of life is actually not any different. And like I mentioned, only 22% of control group actually receive immunotherapy. So the survival benefit that we see may be actually somewhat artifactual. Overall, we still need additional biomarkers. PD-L1 is the first step, but whether it's greater than or less than 50%, clearly we need additional biomarkers to help tease out who may benefit from immunotherapy alone or plus chemotherapy. So hopefully I will have some more updates next year about this. Thank you. Oh, so post-test. All right, so now, same question, 56-year-old never smoker, PD-L1 is high, she has brain and liver metastases, EGFR wild type. What do you agree with the most? Addition of bevacizumab to chemotherapy and immunotherapy can overcome the negative association of liver mets on immunotherapy efficacy. Number 2, patients with brain metastases do not benefit from the combination of chemo and immunotherapy compared to chemo alone. Pembrolizumab is the recommended therapy to this patient because their PD-L1 is greater than 50%. Yay! All right, so that's the right answer. So number 2 is that we've shown that patients who have brain metastases, chemo and immunotherapy, actually the hazard ratio is all to the left, favor the combination. And then pembrolizumab, it's actually not completely wrong because you have data. It's just that subgroup analysis, you have to be careful about using immunotherapy as monotherapy in this setting if they are never smokers, even if EGFR is negative. So second question, for small cell lung cancer, overall survival benefit of immunotherapy compared to standard of care chemotherapy. It's demonstrated with first-line therapy with pembro in PD-L1 greater than 50% as maintenance, chemo plus atezo as first line, nivolumab as second line. All of the above have shown overall survival, or none of the above have shown survival benefit. All right, answer is C. None of the other ones have statistically shown overall survival benefit except for chemotherapy plus atezolizumab as first-line therapy. So, thank you.